Thank you very much. At the outset, I should thank Dr. Vijayakumar for giving me a permission to verbally assault you on a Saturday evening. Respected chairpersons, and especially Dr. Rajendran, who's been my senior in Kilpauk Medical College, and he was associated with the NCC. And I had the misfortune of always listening to him because he was the NCC commander there, and I was very bad as far as march past is concerned, because at that time I wasn't married, or neither I was in the assembly where we keep marching out of the assembly. So he used to make me run around the Kilpauk grounds for not doing the march very well or not wearing the uniform properly. And I'm very happy after 35 years I'm taking a revenge on him by making him listen to me at least for the next 20 minutes. Thank you, Rajendran. My talk today is on rheumatological manifestations of diabetes mellitus. A very interesting physiotherapist I had when I was an assistant professor at the Madras Medical College. His knowledge of English was so good that he would put Winston Churchill to shame. You know, he always used to go and tell the young women, that's why I chose the specialty of rheumatology, because I'll be seeing young, beautiful women with arthritis. He used to go and tell those women there, ma'am, don't get worried. You are suffering only from romantic pain and you'll be all right. This annoyed me very much because I had studied in a British school, and I told him one day, romance is not pain, it's pleasure. It becomes painful only when you get married, and that we speak from personal experience, because some of us fall in love and then get married. Some of us get married and then start loving. So, all of us have a dilemma whom to choose before marriage, and some of us may even have a dilemma after marriage. That's why I coined the term rheumatological manifestations of diabetes mellitus. So I just need to speak and choose what I need to speak to you about this rheumatological manifestations of diabetes. Whenever I start any talk, I always ask my forefathers, should I do it or not? But my great-grandfather never agrees with me. So one reason is rheumatological manifestations of diabetes are giving a stepmotherly treatment in the world, like how rheumatologists are treated. Especially I'm talking this after a very nutritious talk by Professor Narsingham. Medline research, less than 1% of articles are dealing about rheumatological manifestations in diabetes, which means to say that we are getting a stepmotherly treatment as far as rheumatological manifestations are concerned. Now, why should I speak to you about rheumatological manifestations? Number one, certain things can be peculiar to diabetes, especially limited joint mobility or diabetic arthropathy. I do accept the fact that as a rheumatologist, that limited joint mobility can occur in other situations, but it occurs more often in patients with diabetes. The second important fact is, certain conditions are more common in diabetes than the general population, and that is adhesive capsulitis or periarthritis shoulder or a frozen shoulder. The nomenclature doesn't matter, but ultimately the patient has got pain in the shoulder with restriction of shoulder movements. Sometimes it can be a pointer to a diagnosis like Flexor Tenosynovitis. In fact, I happen to be Dr. Venkataraman's colleague in the Madras Medical College. He was in diabetology and I was in rheumatology. Many a time we have seen patients with Flexor Tenosynovitis ultimately picking up diabetes mellitus, and more often even in Apollo Hospital, I pick up patients who come with Flexor Tenosynovitis where they are totally ignorant of whether they are a diabetic or not. So it can point to the diagnosis. It can be a pointer to a microvascular disease, example, limited joint mobility. In fact, Dr. Vijayakumar said today that limited joint mobility can even be a marker for exaggerated pressure on the feet, which can be a marker for a risk factor for developing diabetic foot. Now, there is certain controversy as far as limited joint mobility and microvascular disease. Some studies show that it can be correlated with retinopathy and nephropathy, but some studies do contradict. Well, science is contradictory. What is true today becomes false tomorrow, especially if you take the story of the statins. In fact, the statin story, in fact, is very controversial and continue to be controversial as far as human existence will be there. Why speak again? There is a very poor awareness of the rheumatological manifestations of diabetes even among physicians. and especially the public. The public are the people who suffer from the rheumatological manifestations, and like what Dr. Vijay said, we have to get into some patient education programs. When you talk about diet, cholesterol, and other things, there should also be spoken a few words about rheumatological manifestations, saying that if you have shoulder pain, please see any general doctor. I don't need that they should see only a rheumatologist, but they can see any other person. Pain in the shoulder, pain in the neck, a stiff back, then difficulty in moving the fingers, painful fingers. In such situations, I think people should be aware of the existence that the joints or the muscles can be affected. I would like to tell a point very categorically now today, that if you take rheumatological manifestations in diabetes, it is not the joint which is affected. It is not the joint at all. Diabetic arthropathy, in fact, is a misnomer. It is only the periarticular structures which are involved as a rheumatological manifestations of diabetes. I would never like to get into the pathogenesis and get you confused at this point of time. Late recognition of these disorders associated with significant morbidity and physical disability leading to impairment of quality of life. Would you love to be a diabetic with completely restricted painful shoulders? Life is miserable. You are dependent totally for all the activities of daily living, and I would rather commit suicide and rather have a restricted shoulder mobility. So it is up to us, the duty, to pick up physical mobility and disability in patients with diabetes and treat them as early as possible. The other important point, this can be a pointer for optimizing diabetic care. I do not know what the diabetologists say. They say tight control of diabetes, glycemic control, all this nomenclature I do not understand. But as a layman, as a rheumatologist, good sugar control. That's the only thing I can say. I do not know about academic terms. I'm sorry, I'm ignorant about it. But I have to accept my ignorance also in public. What do I intend to highlight? Is that rheumatological manifestation unique to diabetes mellitus? Is it more common in diabetes than the general population? In which type of diabetes mellitus it is common? Is it related to glycemic control? Is it related to the duration of the diabetes? Or is there any association with the presence of target organ involved damage? And last but not the least, in terms of priority of options of management. Now, one thing, as a rheumatologist, I do not have data, but for the last 30 years, what I see very commonly in diabetic people is periarthritis of the shoulder. I do not know, like Dr. Vijay or somebody should do a study, pick up about 1,000 patients with diabetes, 500 type 1, 500 type 2, pick up 1,000 people in the normal population, and find out the prevalence and incidence of rheumatological manifestations of diabetes there, because I see them when they have a problem. Vijay Venkatraman and Vijayakumar will be seeing them when they do not have a problem. So adhesive capsulitis, the other term is called as shoulder-hand syndrome, which is of no significance. Now the other one which is seen is mainly with the hand. So one important point I'd like to tell you is, if you take rheumatological manifestations of diabetes, it is mainly in the shoulder and the hand. These are the two anatomical areas in the body which are affected. Forget the back, forget the knee, the osteoarthritis. Regarding diabetic foot, I'm absolutely incompetent to talk about that. Now I'm coming down to the hand, the fingers. We have the limited joint mobility. You have flexor tenosynovitis with or without a trigger finger. You have Dupuytren's disease. You have carpal tunnel syndrome. Coming down to spine, I do see a good number of patients with diffuse idiopathic skeletal hyperostosis whose clinical presentation with lower back pain, and very often they are referred to me as ankylosing spondylitis. Foot, I'm not going to talk about it. But in fact, the muscle, we have pyomyositis, especially tropical pyomyositis, which is common in diabetics due to Staphylococcus aureus, asymptomatic, constitutionally very fine, and usually the MRI or the ultrasound picks up, and then they respond very well to antibiotics. I'm not talking of diabetic muscle infarction. So coming down to frozen shoulder, or periarthritis of the sole shoulder, which is the most commonest manifestation of rheumatological manifestations of diabetes. It is not unique to DM, it occurs in other conditions, in fact, especially after myocardial infarction. But it is commoner in diabetes mellitus, 25%, greater than in the general population, only 5%. They say it's related to poor glycemic control, and it's also associated with longer duration of diabetes mellitus, seen both in type 1 and type 2 mellitus. Now, you see this person is not even able to abduct the shoulder. So what I feel is all you diabetologists should examine the shoulder of every patient who's got diabetes. You have to see whether there's any limitation of abduction, any limitation of external rotation and internal rotation. In fact, you can do a passive examination rather than an active examination, and you pick up those patients and you refer to me so that I definitely improve on the monetary front. In fact, somebody told me that, now we are in an era of all of us getting notices from the income tax department. So one of my colleagues, he called me in Apollo Hospital and he whispered to me over the telephone, Ramki, I heard you got an income notice from the income tax department. I said, I'm very happy that I've been recognized as a very rich person, like Malaya or anybody in this world. I'm very happy. Now he told me, I just want to ask you 2 questions. I said, please tell them what are your problems. The doctor asked me, I just want to know why I got an income tax notice. The second question is, what you will do for this income tax notice? How will you go forward? I told him, you first tell me why I got an income tax notice. Second, you tell me how you will address this problem. Then we shall discuss further. And then he said, no, we are all getting into trouble. Everybody is getting this IT notice. I said, don't get worried. In the next 3 months, the Aadhaar card will be replaced by the income tax notice. So what happens, you need not have an Aadhaar card. Just take the IT out, everywhere you can go. That's how it's happening here. I hope no income tax officers here. Anyway, then nothing will happen to me. So you'll have to think of limitation of abduction, limitation of internal rotation, and limitation of external rotation, passive and active. You pick up periarthritis of the shoulder and pick it up early and send them back fine. So the other important problem is these people have severe shoulder pain at night, nocturnal shoulder pain. You'll have to think of periarthritis. You'll have to think of periarthritis due to diabetes, or it can be malignancy, and it will worsen lying on the affected side. This is a very important question, and there will be restriction of both active and passive, abduction, external and internal rotation, and the X-ray of the shoulder will show sclerosis of the greater tuberosity of the humerus, like how it is seen over here. As a diabetologist, well, you need not have an X-ray. You can have an X-ray done, but anyway, we'll get the report from the radiologist, and you pick up periarthritis of the shoulder. Now, periarthritis of the shoulder can be unilateral and bilateral, and often in diabetes, it is bilateral. That's a very important point. Disabling and disturbing, and this is another important question. I also practice a specialty like diabetologist. I practice rheumatology, in which the patient is not cured at all. So when they tell me how long to take treatment, I say lifelong. So one patient came and told me, I have rheumatoid arthritis. How long do I take treatment? I said lifelong. He asked me, your lifelong or my lifelong? I told him, see, the probability is I will die earlier than you because I am elder to you. If I die earlier than you, then you can see another rheumatologist. If you die earlier than me, then there is no problem, you are dead. If both of us are dying, then there is no problem at all, both of us are not there. So that also applies to diabetologists. But the other important problem between rheumatology and diabetology is rheumatological patients suffer from pain. Diabetic patients, they get into so many other complications like nephropathy, ischemic heart disease, and cholesterol and all other problems. They may die a little premature than rheumatological patients. That is why rheumatologists are more prosperous than diabetologists. At least I can say that. In practice, it does not happen. Venkatraman disagrees with me that. That's why I got the notice. The biggest advantage in India is if you earn less, you will get an income tax notice. The more you earn, you will not get income tax notice. Like Nurul Nodi, you can go to America, or you can go to Saturn, you can go to Moon and be very, very happy. And they sponsor it also. See, very, very important point. You will get a loan from the bank only if you have a passport. Unless if you don't have a passport, you will not get a loan. Anyway, let us come back to academics. I'm sorry. And spontaneous resolution within 6 months to 3 years. People with periarthritis will take time to settle. There is no golden rule that you will become all right in 2 months, he'll become all right in 6 months. That is why people with periarthritis do a lot of doctor shopping. And finally, after 3 years, they'll see one doctor. No? At that time, they'll become all right by themselves. and that fellow gets the credit, whereas all the other people get the discredit of not making him all right. So I prefer to be the last doctor seen after 3 years so that my reputation will improve. Unfortunately, it is not so. So I'm neither rich nor I am rich in reputation also. That's why what happened, one day I was going to the temple and somebody said, where are you going? I said, I'm going to the temple. Then he told me, are you going in an Audi car? I said, naane car la Audi to poittu irukken. I am only in an i10 car. I don't have an Audi car. That's the point which I had to tell him. Now, NSAIDs, be very careful in diabetes because they can have diabetic nephropathy. Use it with great caution. Then you have the physiotherapy. Very, very important in adhesive capsulitis is rehabilitation and rehabilitation and rehabilitation. Now, local steroids, lot of studies have shown by injecting an intra-articular steroid, there is a transient increase in the blood sugar, but it is not very risky. So that's very, very important. But the ideal time to give an intra-articular steroid is when the blood sugar is controlled. That's very, very important. If he has got a poor glycemic control, I do not know whether the nomenclature is correct, Venkatraman, poor glycemic control, then in that situation you have to be careful about intra-articular steroids. And this is the last one which has come. In periarthritis, one can do an arthroscopic capsular release. I'm just telling you, surgery is also possible. Limited joint mobility, well, it's seen in unique to diabetes. All politicians have limited joint mobility before the election. After the election goes away, the limited joint mobility completely disappears. The namaste sign or whatever sign people say, I do not know. Then you come down to the skin. The skin in limited joint mobility will have a scleroderma like skin changes, contracture of the fingers. Like what Vijay said, you can also see it in the toes. Usually it is painless. So once a patient comes in, you also do like that and he does like that, you know he's got limited joint mobility. That's an easy way, not like that. It's better to do the Indian namaste and pick up the namaste sign. And this is called the tabletop sign. No? They keep the palm on the table, the palm will not touch the table at all. It's only very discomforting, not very disabling, physiotherapy and good glycemic control. One thing, all rheumatological manifestations of diabetes, physiotherapy, rehabilitation. So I need not keep repeating it again, no? But don't forget, refer to rheumatologist. Now coming down to Flexor Tenosynovitis, commoner in diabetes than in general population, type 1, type 2, seen even before frank onset of diabetes mellitus. Sometimes it can be associated with triggering also. Now this is very, very unique, the Flexor Tenosynovitis in diabetes. If there is involvement of 3 or more fingers, kindly suspect diabetes. That's a very important point. This has come very uniquely in most studies and this is very, very important. 3 or more fingers, kindly think of diabetes mellitus, that's trigger finger. Again, analgesics, ultrasound, steroids. Carpal tunnel syndrome, all of you know, I'm not just going to talk about it. It can occur more common in diabetics than in the general population. And this is the Fallon sign and the Tinel sign, which all of you know, I need not talk about it. Well, important point, medications like pregabalin, you can give a splint to them, that's very useful in carpal tunnel syndrome, local steroids and surgical release. Duputyren's contracture also is a little unique to diabetes mellitus, seen both in type 1 and type 2, associated with the duration of the disease. This is very, very important. Like how the 3rd, 4th and 5th fingers are affected by Flexor Tenosynovitis in diabetes mellitus, Duputyren's typically affects the 3rd and the 4th fingers. While in Duputyren's in other diseases affects the 4th and 5th. So if the 3rd or the 4th finger, you get a Duputyren's, think of diabetes mellitus. Diffuse idiopathic skeletal hyperostosis, very commonly seen in diabetes, especially in type 2. Because they say it occurs in people with hyperinsulinemia and the important presentation is usually they are asymptomatic. If you take X-rays, they'll have excessive calcification of the longitudinal ligament and they have only stiffness. And this is very, very interesting. You will feel very egoistic to say, I picked up diffuse idiopathic skeletal hyperostosis. But it is academic pride, but deflated ego. You can't do anything for that. So sometimes you feel very, I got 150 cases of diffuse idiopathic. What did you do for them? Nothing. I conveyed my condolences. So that is not the point of treatment in medicine, you understand. Right? Like people, in fact, I have more than 3,000 patients with seronegative antiphospholipid syndrome. who have been treated for recurrent pregnancy loss, I think the maximum collection in the world, and people will come and 6 and 7 abortions. You can't go and tell them, extremely sorry madam, we'll have to wait for you, we'll keep on doing the result. By the time the man will attain andropause or the woman will attain menopause. So we have to start treating them, you know. Yeah, I'm sorry, Abba. Yeah, I'll finish. This is the last one. There's a strong association between osteoarthritis and obesity and diabetes. This is very recently come. So diabetic people are more prone to OA. So what is the carry home message? Number one, diabetes mellitus does have rheumatological manifestations. Unique to DIM is limited joint mobility. Then common in DM, periarthritis shoulder is very, very common. This is also very common, Flexor Tenosynovitis. Pointer to diagnosis, Flexor Tenosynovitis, Duputyren, pointed to microvascular complications. Management, be careful with NSAIDs. Pathogenesis not clear. So I like to come to the end of the picture. I tried my maximum ability to keep everybody awake, but there is a lot of research going on in medicine, in diabetes, rheumatology. As people are there burning the midnight oil, I always love to quote Robert Frost and say, the woods are lovely, dark and deep, and I have many promises to keep, and miles to go before I sleep, and miles to go before I sleep. And this slide is for those who have already gone to sleep. Thank you very much.